Welcome to the deep dive. We all hear eating healthy, and, well, it sounds simple enough, doesn't it?
It really does seem straightforward on the surface.
But the truth is, what actually ends up on our plates, how healthy we are, and even, who gets access to genuinely nutritious food,
Hmm.
it's all shaped by these huge, really complex systems.
Absolutely. It's way more than just grabbing an apple instead of a cookie.
It really is. It's so much more than just an individual choice.
Exactly. We're talking about a whole ecosystem of food and health. It stretches from global policies, farming practices, right down to your local grocery store.
Or if you even have one nearby.
Right. It's this massive interconnected web, and it touches absolutely everyone.
And that's precisely what we're trying to untangle today.
Yeah.
This deep dive is all about public health nutrition, or PHN.
Hmm.
Our mission, really, is to give you a shortcut to understanding this really multifaceted world. We want to reveal some surprising facts, connect some dots you might not have seen before, and it's all based on a stack of expert sources.
Yeah, we're going to unpack what it actually means to improve the health of whole populations, not just individuals.
And explore the role of a public health nutritionist, the science they use,
Hmm.
and those deep social and cultural forces that kind of silently shape our diets.
Plus, we'll look at the major global challenges and, importantly, the opportunities for a healthier future.
Okay, so let's start right at the beginning. When we talk about public health nutrition, what are we actually defining here?
Well, at its heart, public health nutrition, PHN, it's about taking a step back from just thinking about one person's diet and looking at the bigger picture.
Right.
It's applying nutrition and public health principles to improve or maintain the best possible health for entire populations or, specific groups within them.
So how does that work in practice?
Think of it like tweaking the whole system, everything from government policies to what your local grocery store stocks, community programs, even the environment you live in. The goal is to make healthy eating the easy choice for everyone, not just, say, people who can afford it or already know a lot about nutrition.
That sounds like a huge undertaking. So the person doing this, the public health nutritionist, what does their job actually look like day to day? Is it all policy meetings? Or are they out in the community?
It's a mix, definitely, but there's a really strong community focus. Our sources describe them as key staff in public health agencies. They're responsible for figuring out what a community actually needs, nutrition-wise.
Assessing needs? Okay.
Yeah, and then planning, organizing, managing, directing, coordinating, and evaluating the nutrition part of health services. But, and this is crucial, they also build bridges. They establish links with other community programs.
Like what kind of programs?
Oh, things like food assistance programs, social services, making sure childcare centers have nutritious meals, working with services for the elderly. It's about building and connecting this whole health ecosystem.
That makes a lot of sense. So it's not just about what you eat individually,
Yeah.
but understanding how whole communities, how everything around them shapes their health.
Exactly.
So what's the science behind all this? What underpins this kind of work?
That's where nutritional epidemiology comes in. It's actually called the science of public health nutrition in some of our sources.
The science of PHN.
Yeah. Think of it like being a detective, but for population health. Its goals are to investigate how diet relates to health and disease risk across, large groups of people,
Yeah.
and to identify which groups might be most at risk, and then develop and test interventions to help people eat healthier. It's all about understanding the big trends, the underlying causes across thousands, maybe millions of people.
It definitely sounds like a specialized role. Requires a lot of expertise. So what does it take to become a professional in this field?
Well, a professional is generally someone who publicly states they have a skill, they've gone through extensive training, got formal qualifications.
Right.
In PHN, an undergraduate nutrition degree is necessary, and graduate-level education, often with that registered dietitian nutritionist or RDN credential, is preferred. But our sources point out a pretty significant challenge here.
Ooh, what's that?
There's currently no specific credential or licensure just for advanced PHN training.
Really? So you can be an RDN, but not specifically trained in the public health side.
Exactly. And this can unfortunately leave some professionals, as one source puts it, ill-prepared to do those core public health functions like assessing a whole community's needs or developing policy.
So there's a gap. Someone could be fantastic working one-on-one with clients,
Yeah.
but maybe not equipped for that broader population level stuff.
Precisely. And the call for the future seems clear from the sources. Ideally, all public health nutritionists should have graduate-level PHN coursework or degrees.
To ensure they're competent.
Right. Competent in those vital areas like community assessment, program planning, implementation, evaluation, and yes, policy development. It really underscores why understanding these basic definitions matters. It helps us appreciate just how broad and critical PHN is for shaping the health of, well, every community.
Yeah.
It's truly a systemic approach.
Okay, so we've sort of defined the players on the playing field in public health nutrition. Now, let's peel back the layers a bit and really get into why this work is so complex. Let's dive into those, hidden forces shaping what we eat and our health.
Yeah, this is where it gets really interesting.
How do public health nutritionists even start to understand all the different things influencing people's diets and health? Our sources bring up a key tool, the social-ecological model, the CEM.
Right, the CM. It's a really crucial framework because it helps us see all these different layers of influence. Think of it like an onion.
Okay, and then
Yeah, at the very center, that's your genes, your personal tastes, your personality. But then as you peel back the layers, you see your behavior is also shaped by things further out.
Like what?
Like your home environment, your immediate community, the wider social scene, and ultimately big policies and cultural factors way out on the edge.
And they all interact.
That's the key insight. All these levels interact constantly. They all influence your behavior, which makes that idea of individual choice a lot more complicated than it first seems,
So it's not just about willpower. It's this whole web of influences, which leads us straight to the social determinants of health, or SDOH.
That's exactly right. SDOH, they're defined as the conditions and the environments in which people are born, live, learn, work, play, worship, and age.
Wow, that covers everything.
That affect a wide range of health, functioning, and quality of life outcomes and risks. And our sources really highlight place, just where you live, as a super important factor, especially in communities with fewer resources.
So your zip code can genuinely affect your health opportunities.
It absolutely can. And within that, we find this critical concept of food justice.
Okay, what does food justice mean?
Food justice is defined as the struggle against racism, exploitation, and oppression taking place within the food system. It's about recognizing and then tackling the root causes of inequality that decide who gets access to healthy, affordable, and culturally appropriate food.
It connects those big systemic issues directly to what's on people's plates.
Precisely. It shows how these things affect health at every single level of that social-ecological model we just talked about.
And we see really stark examples of these health disparities when we look at things like food deserts and food swamps. Can you break those down for us?
Sure. Food deserts are geographic areas, often low-income neighborhoods where there isn't a supermarket within, say, a mile if you're in a city, or maybe 10 miles if you're in a rural area.
Wow, a mile doesn't sound like much, but if you don't have a car.
Exactly. Imagine living in a city and needing to take 3 buses just to get to a store with fresh fruits and vegetables. One assessment mentioned in the sources found that in low-income areas with low food access, they also had the highest rates of child and adult obesity and type 2 diabetes.
And food swamps. That sounds unpleasant.
It is. It's the flip side, kind of. Food swamps are places with a really high concentration of junk food businesses, fast food places, convenience stores compared to healthier options like grocery stores or farmers markets. So you might have plenty of places to buy food, but not much nutritious food.
So you're surrounded by food, just not the right kinds, like a cruel paradox. And these challenges, they're different depending on whether you're urban or rural.
Right.
Even for people with low incomes.
They really are. Someone poor in a city might face, cost barriers or trouble getting transport to a clinic or a good store. But someone in a rural area might just be dealing with the sheer distance to any provider or healthy food source. Miles and miles.
And that has real consequences.
Absolutely. One source notes that between 1999 and 2014, rural areas consistently had higher rates of premature death adjusted for age from things like heart disease, cancer, chronic respiratory disease, and injuries compared to cities.
Wow. Okay, so beyond where you live and your income, culture plays a huge role in all this, doesn't it? It's not just a factor. It seems like it's fundamental.
It really is. Culture isn't just a factor. It's like the bedrock of what we eat and how we see ourselves through food. One source calls it a foundational imperative for food choice and identity. It influences our habits, our choices, our morals, even our codes of practice around eating.
It's deep.
Yeah. The sociologist Pierre Bourdieu even argued that class structures are actually cultural structures, meaning what we eat is deeply, deeply tied to our social identity.
And this becomes really obvious when public health programs try to cross cultural boundaries. Our sources give this really vivid example comparing a program in France, EPO'd, with one in Australia, OPAL.
Oh, yeah, that example really highlights the human element, doesn't it? Both programs were trying to prevent childhood obesity.
Right.
But EPOD in France, it focused on preserving cultural and traditional habits around food, things like enjoying meals together, taste education. Opal in Australia, though, it took a more direct approach, trying to disrupt and replace habits, more instructional.
And the results were different.
Well, the approach certainly was, and it reflects cultural differences. Even the language shows it. Like in English, we say, I'm full, but the French equivalent is je n'ai plus faim, which literally means I am not hungry anymore.
Huh. Subtle difference.
It is subtle, but it reflects something deeper, right? A focus on desire or hunger versus just physical capacity. It's like trying to translate a joke perfectly, you might get the words right, but lose the actual humor.
With the effectiveness in this case.
Exactly. It really shows why just taking a program that works somewhere else and dropping it into a new culture without really understanding that culture, it often just doesn't work.
So for PHN professionals working with really diverse groups, what's the best way to avoid those kinds of pitfalls?
The advice from the sources is clear. Go beyond their evidence-based practice resources and strive to assess and meet the community where they are. You have to understand their context.
And one way to do that is through community health workers, or CHWs.
Yes, CHWs are a vital model for this. These are people from the community itself. They often share the same ethnicity, language, cultural background. They act as trusted links, as educators, bridging that gap between healthcare systems and the people precisely because they get the lived experience. They have that trust.
That makes sense. And for specific groups like immigrants and refugees, their situation is even more complex, right?
Right.
Even their legal classification can impact their access to services.
It absolutely does. Refugees, for example, they might get temporary access to programs like Medicaid, SNAP, PWIC for maybe up to a year when they arrive,
Right.
which is crucial.
But it's temporary.
It's temporary, and even with that help, they're still incredibly vulnerable. They might have faced war, trauma, maybe years of statelessness. The source mentioned Burmese refugees specifically, who, after decades of statelessness, maybe in rural camps or tough urban settings, arrived lacking basic health literacy, job skills, education. It makes adapting and navigating a new, healthy life incredibly difficult.
It really just hammers home how these big systemic issues, these cultural factors, they're often invisible to many of us, but they have such a profound impact on our daily food choices and health. It makes PHN seem absolutely critical for equity, for well-being. Okay, we've seen the complex web of influences. Now, how do public health nutritionists actually try to make a difference? What are the tools and strategies they use on the ground, and what's the science behind choosing those tools? Let's talk about evidence-informed practice. What kind of research do they rely on?
Right, so they use various research methods to figure out what works. One common type is cross-sectional studies.
Cross-sectional.
Yeah, they basically take a snapshot in time. They collect data from a group of people at one single point, often using existing records, maybe. They're usually cheaper and quicker to do.
But what's the catch?
The big limitation is they can't really determine cause and effect. For instance, a study might find that people who eat more fish tend to have lower BMIs.
Okay.
But you don't know if eating fish causes the lower BMI, or if maybe people with lower BMIs are just more likely to choose fish, or maybe there's some other factor involved entirely.
Correlation isn't causation.
Exactly. So you see headlines like X causes Y based on these studies, but really it's just X and Y we're seeing together. It's a really important distinction for, anyone reading health news.
Good point. What else?
These studies can also have biases, like sampling bias. Maybe you only surveyed people who shop at one type of store. Or recall bias, people might not accurately remember what they ate last week or last month.
Okay, so what about studies that can get closer to cause and effect?
For that, you have things like case control studies. These look backwards, they're retrospective. They compare a group with a disease, the cases, to a similar group without the controls to see what past exposures might have been different between them.
Looking for clues in the past.
Right. And then there are cohort studies. These are powerful. You recruit a group of people, your cohort, and follow them over time. You see who gets exposed to something, maybe a certain diet pattern, and who doesn't, and then track who develops a disease or outcome.
So you follow them forward.
They can be prospective, following people in real time, or they can be retrospective, using past records, but still tracking exposure and outcome over time. These give you much stronger evidence about cause and effect.
And when they use this research, is it always strictly evidence-based practice? I feel like I hear that term a lot.
You do hear EBP, evidence-based practice, but increasingly the term evidence-informed practice, or EIP, is used and maybe preferred by some.
What's the difference?
EIP acknowledges that real life isn't a perfect lab study. It takes the research evidence, sure, but it also explicitly accounts for uncertainty in that research, for the clinician's or practitioner's interpretation, and really importantly, for the actual needs and preferences of the patient or the community.
So it's more flexible, more real-world oriented.
Kind of. It recognizes that the best evidence might need tweaking based on context. And there are resources, like the Equator Network, that provide checklists and guidelines to help researchers design and report studies rigorously, which helps build that evidence base.
Okay, so they have this evidence, this understanding. How do they translate that into actual interventions in the community?
Right.
What are some practical tools that help families get healthy food?
Well, a big part is leveraging national resources and federal programs, things many people have heard of, like the USDA's Supplemental Nutrition Assistance Program, SNAP.
Right, SNAP.
Yeah.
Formerly food stamps.
Exactly. That helps low-income families afford groceries. And then there's WIC, the Special Supplemental Nutrition Program for Women, Infants, and Children.
WIC, yeah.
WIC provides specific healthy foods, plus nutrition education and support for pregnant women, new moms, infants, and young kids. These programs are fundamental for making healthy foods accessible for millions.
So these aren't just like obscure government things. For
Sure.
a family that's struggling, what's the actual impact of SNAP or WIC day to day?
Oh, they can be absolute lifelines. Take a specific WIC program, the Farmers Market Nutrition Program, or FMNP.
Got it.
That gives WIC participants vouchers specifically to buy fresh fruits and vegetables directly from local farmers at farmers markets. It connects local agriculture with families who really need that fresh produce.
That's great. Double benefit.
Yeah. And another one, the Child and Adult Care Food Program, CACFP. That offers subsidies, basically reimbursements, for meals and snacks served in places like childcare centers or adult daycare. It helps ensure kids and vulnerable adults get good nutrition even when they're not at home.
And beyond just getting food, what about education?
Education tools are key too. Things like My Plate, that visual guide for healthy eating, and food labeling resources from the USDA's Team Nutrition Initiative. But again, like we talked about with culture,
Adaptation is crucial.
yes, these tools need to be culturally adapted so they actually resonate with the diverse groups people are working with. A generic handout might not connect.
It really sounds like engaging the community directly is essential for any of this to work well. It can't just be top-down.
Absolutely. It's the cornerstone. Community engagement means truly involving the public, the people you're trying to serve, in setting the agenda, making decisions, shaping the programs and policies.
So not just telling them, but asking them.
Exactly. Asking them what they need, what their priorities are, how they think things should be done. Our sources mention some really cool, innovative tools for this, like crowdsourcing ideas online or photo voice.
Photo voice, what's that?
That's where you give people cameras and ask them to take pictures that represent their community's health challenges, but also its strengths. It's a powerful way for people to tell their own stories and advocate for change. It really shows the ingenuity communities have when they're actually empowered, doesn't it?
It really does. And we have some fantastic real-world examples in our sources that show PHN in action, putting these principles to work.
Yeah, some great ones. Like one example involved a coalition that found low food access and high rates of obesity and diabetes in certain areas of a state.
Okay.
They got a grant from the Robert Wood Johnson Foundation and launched mobile food markets, like grocery stores on wheels.
Bringing food to the food deserts.
Pretty much. And they didn't just show up. They used all sorts of marketing, social media, flyers, and SNAP offices, working with schools, radio ads, even billboards to make sure people knew they were coming and could access healthy, affordable food right in their neighborhoods.
That's brilliant. What else?
There's the Community Engagement Project in McDowell County, North Carolina. This intervention holds regular open forums just to listen directly to residents.
Just listen.
Yeah, to understand the community's assets, their needs, their challenges, all with a strong focus on health equity. They literally go to the people to get input, making sure the solutions fit the local reality.
And community gardens seem to be popping up everywhere. They seem to embody a lot of these ideas.
They really do. Community gardens are becoming super popular. They're seen as effective ways to, revitalize neighborhoods, build social connections, what researchers call social capital, create a sense of belonging, and obviously increase access to fresh, healthy food.
Multiple benefits again.
Definitely. They nourish the body and the community's spirit. And there are policy examples too, like the Live Well Greenville initiative in South Carolina. Back in 2012, they successfully pushed for a policy change requiring healthy snacks in all city-run after-school programs. That's a great example of tackling those social determinants through a systemic, socio-ecological approach.
So all these initiatives, they need careful planning and evaluation to know if
Yeah,
they're working.
absolutely. On a national level, you have efforts like Healthy People. It gets updated every decade and sets evidence-based health goals and objectives that local communities can then adopt or adapt for themselves.
Like a national framework.
Exactly. And for specific programs, they use tools like SMART goals. That stands for specific, measurable, achievable, relevant, and time-bound. Helps keep planning focused and effective.
Or goals, right?
And logic models are another really useful tool. They're like visual maps showing how an intervention is supposed to work, the inputs, activities, outputs, and the expected short-term and long-term outcomes, like a roadmap for the program.
Okay, and once they have these programs planned and running, how do they get the word out? How do they communicate all this important health information?
They use a whole toolbox of communication strategies. It could be interpersonal, a doctor talking to a patient, a community health worker visiting a home. Telehealth is increasingly important too, especially for reaching rural areas.
Makes sense.
Then there's print materials, flyers, posters, promotional items sometimes, mass media campaigns on radio, TV, billboards for broad reach, and of course, online channels are huge now.
Social media.
Yeah.
Apps.
Yep. Social media, websites, and also mHealth using mobile phones. That could be for collecting survey data quickly, sending out health tips via text message, using apps for tracking or education. It's about meeting people where they are, using the channels they already use.
It's really clear that PHN isn't just theory. It's incredibly practical, using science, using community wisdom to create real, tangible change. We've seen the tools and strategies used at the community level, which are powerful. But these nutrition challenges, they don't stop at national borders, do they?
Not at all.
When we zoom out, we see these same issues playing out on a massive global scale. And they get tangled up with even bigger questions about the future of our planet.
It's all interconnected.
Our sources talk about something called the double burden of malnutrition. Now, that sounds like a contradiction. How can people suffer from too little nutrition and too much nutrition at the same time, sometimes even in the same place?
It is a paradox, isn't it? But it's a harsh reality in many parts of the world. You can literally find in the same country, sometimes even in the same household, a child who is stunted from not getting enough nutrients and a parent who is struggling with obesity.
How does that happen?
It's often driven by poverty and changes in the food system, specifically the widespread availability of cheap, highly processed foods that are packed with calories but lack essential vitamins and minerals.
Empty calories.
Exactly. So on the undernutrition side, we still see major micronutrient deficiencies globally. Things that sound small but have huge impacts. Like imagine a child's brain not developing properly just because they lack a tiny bit of iodine. Iodine deficiency affects about 13% of the world's population.
13%.
Yeah. Zinc deficiency leads to growth failure. Vitamin A deficiency can cause night blindness, even permanent blindness. And on top of that, infectious diseases like tuberculosis and HIV make malnutrition much, much worse. They create a vicious cycle.
And then the other side of that double burden, coin over nutrition, is also a massive global problem, often linked to those same cheap processed foods.
It absolutely is. Obesity is now officially designated as a disease, and it contributes to around 4 million deaths every year worldwide.
4 million.
It's strongly linked to what we call non-communicable diseases, or NCDs, things like cancer, heart disease, type 2 diabetes, respiratory illnesses. And there's another interesting link our sources mention: stress.
Stress affects diet.
It seems so. Stress hormones can actually increase cravings for those high-sugar, high-fat foods. This creates a really difficult cycle, especially, say, for food-insecure women who might face chronic stress from poverty or instability.
Wow. And these nutrition challenges, they really affect people across their entire lives, don't they? From before birth right through old age.
They really do. It starts incredibly early. The nutritional environment in the womb is linked to a child's risk later in life for developing heart disease, type 2 diabetes, obesity.
So what happens to the mother affects the child decades later?
Yes. Studies on famine, for example, show that experiencing famine during early, mid, or late pregnancy can predispose the offspring to chronic diseases way down the road. And most stunting, that failure to grow properly and wasting, being dangerously thin, happens in the first 2 years of life. That's when nutrient needs are incredibly high, and kids are also very vulnerable to infections.
Okay, and what about maybe a population people don't always think about in this context? College students.
Right. It might surprise some listeners, but financial hardship is a huge, often hidden barrier to health for college students.
Because tuition is so high.
That's a big part of it. Our sources point out that the average net price for in-state public universities nearly doubled over 30 years. So students rely heavily on loans, not just for classes, but for basic needs: rent, food, healthcare.
And campus food isn't always cheap either.
Exactly. Even the least expensive campus dining plans can cost more per meal than the USDA's Thrifty Food Plan, which is the absolute baseline budget for a nutritious diet. This financial squeeze directly impacts their ability to eat well and stay healthy. And yes, the sources also mention binge drinking as another health concern in this group.
And older adults face their own specific set of challenges too, right?
They do. About 7.7%, almost 8%, of older adults are food insecure. They often have to make really tough choices, trade-offs between buying food and paying for medicine or housing, especially with high medical bills and housing costs.
Plus mobility issues.
Yeah, losing mobility can make it hard to shop for groceries or even prepare meals. And we also see disparities here. Minority older adults often have higher rates of chronic conditions like hypertension and diabetes, adding another layer of complexity.
This all seems to tie into the much bigger picture of the sustainability of our entire food system.
Absolutely. It connects directly to global goals, like the UN Sustainable Development Goals for 2030. Addressing nutrition isn't just about food. It means tackling poverty, inequality, improving education, ensuring access to clean water. It's all linked.
And our current food systems are under enormous pressure.
Huge pressure. From climate change, from a growing global population, from rapid urbanization, changing how and where people live, and just from the way our food systems themselves are changing, often towards more large-scale industrial models.
And this leads to a really fascinating, maybe even radical idea mentioned in the sources, the concept of rights of nature. What is that?
This is a really groundbreaking legal and philosophical shift. It's a framework that argues that ecosystems themselves, think oceans, rivers, forests, mountains, have inherent rights.
Right, like human rights.
Kind of. The right to exist, to persist, to maintain their vital cycles, to regenerate. It moves beyond the idea that nature is just property, just resources for humans to exploit.
So a river could have legal standing.
That's the idea. Imagine a factory couldn't just pollute a river, because the river itself, as a living entity, could legally demand protection, maybe even sue for damages to restore its health. There are real-world examples emerging.
Like where?
Bolivia included rights for Mother Earth in its framework, and in the U.S., residents of Toledo, Ohio, actually passed a local law recognizing Lake Erie's right to exist and flourish, empowering residents to sue polluters on behalf of the lake.
Wow. How does this connect back to food and nutrition?
Well, think about it. If we legally recognized the rights of soil to be healthy, the rights of rivers to be clean, the rights of pollinators to thrive, it would force us to design food systems that work with nature, that regenerate it, not just extract from it. Because the health of that soil, that water, directly determines the health and nutrient quality of our food, and ultimately our own health. It's a profound shift away from purely human-centered thinking.
That's a really powerful concept to mull over. And even within our current systems, there's still this huge, glaring problem of unequal distribution and waste.
It's stark, isn't it? The U.S., for example, exports something like $140 billion worth of food annually. And estimates suggest we waste up to 40% of our food supply somewhere along the chain. 40%.
40% wasted.
Yet, about 12% of the U.S. population is food insecure, mainly because of poverty. We have the food, it's just not getting to everyone who needs it, or people can't afford it.
So what's a potential solution there?
Well, the UN and other major research institutes point towards agroecology. These are farming approaches, often on smaller scales, that mimic natural ecosystems. They use fewer chemical inputs, build soil health, conserve water, and can actually be very high-yielding. They're seen as a key strategy for boosting global food security in a sustainable way. It's about working with nature's systems.
Finally, let's touch on food policy itself. It sounds incredibly complex, and sometimes policies even seem to work against each other.
It really is complex. Policies can have all sorts of knock-on effects, sometimes unintended ones. And yes, you definitely see what the sources call concurrent contradictory
Right.
policies. The example given was in the EU, where there might be efforts to support local dairy farmers, but at the same time, relaxed import quotas that actually incentivize global competition, potentially hurting the very farmers they were trying to help. It's a tricky balance.
And in the U.S., the Farm Bill comes up every 5 years or so, and it's always a huge debate.
Oh, absolutely. The Farm Bill is this massive piece of legislation. The 2018 one allocated around $86 billion per year. The biggest chunk of that budget is SNAP, helping over 42 million low-income people.
That's huge.
It is. And the debates around it are always intense. Should SNAP be separated from agricultural subsidies? Should farm support be linked more closely to nutrition goals to benefit both farmers and consumers? It really shows how deeply intertwined our food production, social welfare, and health systems are.
And the global health cost of poor diets is just staggering.
It's immense. The Lancet Global Burden of Disease report estimated that inadequate diets contribute to 11 million deaths globally each year from those non-communicable diseases we mentioned.
11 million deaths a year from diet.
Yeah. And diets low in whole grains, low in fruits, and high in sodium were responsible for more than half of that NCD mortality. There's also the ET Lancet Commission report, which laid out a framework for what an optimal diet for human health and sustainable food production could look like. The key takeaway is you can't achieve one without the other, and it requires everyone, governments, industry, individuals working together.
It truly drives home that our plates, our planet, our policies,
Yeah,
they are all fundamentally connected.
they absolutely are.
It's clear the challenges are global, they're interconnected, and they really demand systemic thinking and active participation from all of us. Hashtag tag tag outro. So we've really taken a deep dive today into public health nutrition. It's clearly this dynamic, really interdisciplinary field that's all about improving the health of whole populations.
Yeah, moving way beyond just individual food choices.
Right, to address those really deep-rooted social, cultural, systemic issues that shape our well-being in ways we might not even realize. We really hope this journey has given you a useful shortcut to understanding this vital and, well, pretty complex world.
And as you think about everything we've discussed, here's something to maybe chew on. Consider how embracing a legal concept like rights of nature, this idea that ecosystems themselves have rights to exist, to persist, to regenerate, how that could fundamentally reshape our entire approach.
Reshape our approach to food systems, to sustainability, to human health.
Exactly. What might a food system actually look like if it was designed with the rights of a river or the rights of the soil truly in mind? Could that kind of thinking lead us toward a future where healthy food is abundant, accessible, and genuinely restorative, not just for people, but for all living things?